Joining us from the Public Safety Training Academy for another episode of Challenges in the Streets. Before I introduce today's episode, I do want to take a moment since our last episode was just a day before the tragic line of duty passing of Lieutenant Chris Higgins, just to take a moment of silence for everybody to remember the life and service of Lieutenant Chris Higgins. Thank you. So as I said, we're here at the Public Safety Training Academy in our studio here, joined by a couple guests from both in the department and outside the department to talk about the topic of preventing custody deaths. It's not a topic that people like to talk about, I don't think, but it's something that's become prevalent over the last couple of years, nationwide especially. This is not specific to Montgomery County. So we brought in a panel to just discuss this and what we do in Montgomery County to prevent this and some best practices for our EMS providers. So before we get into it, just remember, if you are a chief officer and you need COPDI credit, to follow the link under quick links to fill out the COPDI form to earn your credit for this episode. We're scheduled to go 90 minutes. We'll try to keep it right about there between our discussion and presentation. In addition to that, if you have any questions, please enter them in the chat. We are live, and Battalion Chief Light is monitoring the chat, and hopefully we'll get to any questions that you might have for our panel or just general points of discussion. So to get right into today's episode, again, I'm not really going to steal the thunder and the point of it. I'll just introduce our panel, and we'll get right into it. So we're joined by our EMIHS section, some of our members. So we have Dr. Stone, our medical director here. We have Captain Leigh Renard here, who is now EMS 703 on A shift, correct?
Mm-hmm. Yep.
We have paramedic Andrew Tuzio, Fire 3 paramedic from Company 11A, as our field provider. And we're joined by our outside member of the panel, Eric Jaeger, who is a paramedic attorney from New Hampshire, and he's also a national EMS educator. So thank you very much, Eric, for joining us. And I think it's really important that we get some outside perspective. So just to bring that outside view and tell us about what we're doing and how we could be better. So Eric, I'll turn it over to you so you can explain what this is all about and why you do what you do.
Fantastic. Well, thank you so much to Montgomery County for the invitation to come down and talk about this incredibly important topic. What I'm going to try and do is give you a quick outline of some of the concerns that we've seen in some of these incidents happening nationwide and talk about how we should modify our approach before we get into a conversation where we delve into some of how some of these topics apply, in particular here in Montgomery County. I am a EMS educator and RSI paramedic. I'm also an attorney, and before that I went to MIT for computer science. It is in fact true that I cannot decide what I want to be when I grow up.
You still have time.
Yeah. Oh, I'm sure this isn't my last gig. So we need to have a conversation about the risks of managing agitated patients, excited delirium, death in custody, and we are going to be challenging some of the assumptions and dogma we've long held in EMS. I want to be super clear on this topic that I'm not going to pretend I've got all the answers. I have important questions, though, that I think need to be addressed, and it's exactly this kind of conversation that we're having here today that gives us all the opportunity to come together to try and come up with better approaches to managing these patients. And the key, I want to say it right up front, the key is, yes, of course, keeping patients safe, but for me, this is every bit as much about protecting EMS providers from liability and protecting our law enforcement colleagues from liability, because when these tragic incidents occur, we typically see sometimes lawsuits, sometimes criminal charges. It's distressing to see these, and I personally have made it a focus of mine to try and reduce the risk to patients, but also to protect our colleagues. Some take-home points right at the front. We have misapprehended the danger of physical restraint and death in custody. This creates risk not only for our patients, but for us as healthcare providers and for our law enforcement colleagues. Excited delirium, a concept I taught as an EMS educator, is a flawed concept that has led to great harm, and it needs to be removed from your lexicon, from your training, and as you've done here in Montgomery County, from the protocols. We have to radically reframe our approach to physical restraint and chemical sedation to enhance safety. We are going to be discussing and viewing some video clips of tragic incidents where patients died. I want to be super clear on this point. We are not about judging the EMS providers or the police officers who were involved in these deaths. They were tragic. Our goal really is to look at these so we can figure out what we can learn from these incidents to keep future patients and our providers safe.
And I think as we're watching these, something important to note that this is for everybody, right? Just so everybody watching understands that it's from a company officer perspective, being in charge of scenes from an EMS duty officer perspective, from a field paramedic, and also, you know, a field BLS provider. There's things that you should be doing as best practices, and you could take something away from any role that you're in.
Now, I think that's exactly right. We are going to talk about chemical sedation, and sometimes when we talk about that, we think, well, that's a paramedic topic, but this issue of avoiding death in custody really is, as so many things are, BLS at its core with ALS layered on top.
Right. I would also add that in a organization like ours that practices just culture, one of the things that we do is we share best practices, things that have worked for us, but we also look at national literature and national trends about what's going on around the country, and that has a nexus to Chief Scott's shop in quality management. What we do is we try to take these lessons and not approach them from a point of finger pointing, but how do we use trends and data from within and without to then modify protocols, have lessons learned by the ALS and BLS clinicians so that they can apply what they've learned to future situations. And that's really part of the quality management mantra and why we apply it so carefully. And this is one of the topics where it's very, very cogent.
I think that's exactly right, Dr. Stone. So our conversation is really going to start off with Elijah McClain. Many of you may have heard this name. He tragically died in Aurora, Colorado in August 2019. And this case brought this issue to national attention. Elijah McClain was walking down the street. He'd purchased some Twinkies at a convenience store. Someone called 911 to report a suspicious person. The police appropriately responded, intercepted him, stopped him. Things quickly escalated. They ended up restraining him on the ground. EMS was called, and ultimately one of the paramedics administered 500 milligrams of ketamine. He's unconscious when they get him up off the ground. He goes into cardiac arrest a short time later. ROSC was obtained. They recovered a pulse, but he died a few days later due to an anoxic brain injury. And I think this case really focused attention on this topic, in part because we saw something unusual happen here. The police officers involved in his death were criminally charged, and the two paramedics involved in providing care to Elijah McClain were also criminally charged and found guilty, and one of them was sentenced to jail time in connection with his death. And what really made this difference, and I think different and shook a lot of people up, is sure, occasionally you see EMS providers criminally charged when they've done something intentionally wrong. No one alleges here that these paramedics intended to harm Elijah McClain. Instead, the criminal charge was based on this concept that they were so criminally negligent that they could be criminally charged. And you could translate that into they were criminally charged for a failure to follow their protocols, and that shook a lot of people up. When you take a broader look at this topic, the AP News came out with a story this past year focused on lethal restraint. They found over 700 deaths involving prone restraint over a decade, and about 100 of those involved chemical sedation by EMS or the ED. So this, for me, kind of blew the scope of the problem up from a small number of cases to now we're talking about over 100 cases involving chemical sedation that had led to death. I do want to mention one other case. This is Jamie Britt. He died about a month after Elijah McClain in Mount Pleasant, South Carolina, September 2019. 50-year-old travel lift operator, local boatyard. By all accounts, a really nice guy. Stopped to change a flat tire. South Carolina cops stopped to check that he was okay. Unfortunately, Mr. Britt had been driving while intoxicated. His initial interactions with police were polite, yes ma'am, no ma'am. But when he was told he was going to be arrested and his car impounded, he became upset and police restrained him on the ground. We're now going to see one of those videos I mentioned to you. And again, I want to emphasize the goal of this is not a video from Montgomery County. This is from somewhere else. We're going to see police interactions and EMS interactions. And the goal here is just to give us the opportunity to learn from what occurred. You can see Jamie Britt on the ground. He's being restrained. And what you'll see shortly into the clip is paramedics show up and administer 500 milligrams of ketamine. And for folks watching out there, I want you to pay careful attention. What kind of assessment is done on Jamie Britt before the ketamine is administered? What kind of monitoring is available by Jamie Britt when the ketamine is administered? And then in the second part of the clip, we'll see what happens after they take Mr. Britt up onto the stretcher, and I want you to, in particular, note where the focus of the individuals are who are caring for Mr. Britt.
I didn't do this wrong. swear to God, I'm not hurting nobody. God damn it.
You can see that he's shackled, his hands and feet, and being held down by a combination of police and EMS and fire.
Go ahead and pop out. Pop out. Pop out.
You got it right there.
There you go. We'll go right here.
That's a paramedic right there.
God damn it.
Yeah. We good.
All right. Just don't stab me. Thank you, sir.
What is this?
It's a little medicine to make you just a little, have a good time.
Please.
There you go. Safety lock.
Stay down.
Give us.
I didn't do nothing.
Here, I got it. Let me rub it in.
Please let me go. Please let me go.
We will. Just
Please
relax.
let me go.
Just relax, okay?
I swear to God, no.
Give us just another minute or two.
You're good.
It'll start working, okay? We had to
From spitting on anybody, you know. He has just a little gash on
Please
his
let
eye.
me go.
It's okay, buddy. Hey, listen,
Please
Mr.
let
Britt,
me
just
go.
relax. Just relax, buddy.
This is wrong.
No, it's not. No, it's not.
Yes, it
Listen,
is.
it's for everybody's safety, buddy.
Oh
It's for
my
everybody's
God.
safety. Okay? Everybody's safety. All right, just relax,
I want
okay?
to die.
No, you're not gonna die. You're not gonna die, buddy.
Oh.
It's okay. It's okay.
No.
All right, listen. Hey, buddy, Mr. Britt. You allergic to any medicine? Mr. Britt. Mr. Britt, are you...
Please let me go.
Mr. Britt.
This is wrong.
Mr. Britt.
You
Are you...
motherfuckers.
Hey, look
I
at...
can't win.
Hey,
I swear to God, I'm not gonna do that.
listen. Are you allergic to anything?
No.
All right. Do you take any medicines?
Let me go.
No. Listen.
Yeah, I do.
What do you take?
High blood pressure.
What medicine do you take?
Lisinopril.
All right. Anything else?
No.
No. All right.
Man, y'all motherfuckers.
Just getting there.
Come on, now.
Hey, just relax.
Come on,
Hey, relax.
now.
Quit doing this, okay?
No.
Listen.
So in that first clip, we see them administer the ketamine. You could hear his sonorous breathing before the ketamine was administered. He's prone on the ground. You can hear he's struggling a little bit to breathe. As I mentioned already, we don't see any assessment done before the ketamine is administered. And these paramedics are operating within their protocol. They are intending to keep Mr. Britt safe and the other providers there safe. And this is something that we rolled out to paramedics years ago, the use of ketamine and other sedatives for this purpose. I'm going to next play you this next clip. This is what happens immediately after. They've already gotten Mr. Britt up onto the stretcher. And I want you to pay careful attention to Mr. Britt's breathing and then the interactions of the providers with him.
Let's
Hello, confirmed Mondo Crossing. You said it'll step outside immediately all in about 2 minutes.
There you go.
Incident 5.
And kind of take it nice and easy over there to East Cooper on the way over. And we'll see y'all there. I don't think he's gonna get up. So I don't think I'll need anybody to ride unless y'all need somebody to ride. No, definitely. He'll follow behind. Okay. He's not breathing. Okay. Oh yeah, he's good. All right. He ain't getting out. If he gets out, we got problems.
Have we requested a tow for this yet?
He hasn't taken a breath in 30 seconds.
Jackson, can you take this camera?
Still no breath.
Go bagging?
So they start to perform bag valve mask ventilation. They note that Mr. Britt's heart rate's very low in the 40s. He's peri-arrest. He goes into cardiac arrest in the back of the ambulance. They resuscitate him. They do, again, obtain ROSC. They transport him up to the hospital. Unfortunately, he dies a few weeks later from an anoxic brain injury. And I think, again, I want to emphasize the paramedics in here thought they were trying to help this patient and protect this patient, and yet once they get him up on the stretcher, there is no monitoring equipment there to keep an eye on Mr. Britt's respiratory status. There is, and we see him agonally breathing, and then he stops breathing. And the hope would be that the paramedics recognize that and are immediately ready to step in with a bag valve mask. But because we don't have any resuscitation equipment right there at the scene, they're unable to do that. I think they recognize what's happening. They move quickly to the ambulance to begin that resuscitation, but unfortunately, it's too late. Let's talk for a minute about excited delirium. For years, when we've seen these videos, we see someone walking down the street, perhaps on meth, on coke, shirt stripped off, sweaty, talking agitated and deliriously. Police encounter them. They do the appropriate thing. They attempt to gain control of the situation. They've toned for EMS. We're on the way. And they'll often have to, because these individuals are combative or agitated, they'll have to take them down on the street, get handcuffs on them. And moments later, they recognize that the individual has stopped breathing, at times gone into cardiac arrest. They roll them over. They begin CPR. And when they inevitably die, we say, oh, we know what that is. That's excited delirium. This concept that someone in particular on a stimulant medication can effectively exhaust themselves to death, become hyperthermic, deplete their catecholamines, become profoundly acidotic. Here's the problem, though. Excited delirium is a flawed concept. There was a AMA report, American Medical Association report, that came out a few years ago. They took a hard look at this concept of excited delirium and said, when we look at these cases, what we see is restraint leading to death, that this concept of excited delirium is not a real diagnosis. And so we've gone back and taken a hard look at it, recognized the science on which this concept was based was flawed, and it's now been removed from every major medical organization around the country has recommended that we move away from the concept of excited delirium. And even the major medical examiner organizations, those folks who provide advice to coroners and medical examiners, have said excited delirium should no longer be listed as a cause of death in coroner reports. It was a myth that people die from excited delirium. But if Jamie Britt and Elijah McClain didn't die from excited delirium, well, what did they die from? It's critically important as EMS providers and healthcare professionals that we understand what the real pathophysiology is if we hope to prevent this from occurring and resuscitate people when it does occur. Let's talk for a second about ketamine. In the Elijah McClain case, it was alleged that they had given him an overdose of ketamine. He received 500 milligrams of ketamine. It was the appropriate dose for someone weighing 200 pounds, but Elijah McClain only weighed about 140 pounds. The correct dose for Elijah McClain would have been in the 300 or so range. And there's been a lot of focus on, well, did he die due to the toxic level of ketamine that they administered? And I got to say again, I'm not a forensic pathologist. I'm not going to pretend I know the definitive answer to that question. But we actually have pretty good evidence that ketamine is safe even at very large doses. There's a study regarding in-hospital accidental ketamine overdoses in children. They accidentally received 5 to 100 times the intended dose. None of those kids died. None of them suffered any adverse effects. They simply remained disassociated for longer. The take-home message here is there really is no, of course we need more research on this, but there is no toxic dose of ketamine. It's safe in and of itself, even at high doses. So again, this brings us back to the question of what caused Elijah McClain, Jamie Britt, and so many others to die in these circumstances. And we've got a pretty good idea at this point. Positional asphyxia due to prone positioning with weight on their back or side for an extended period of time. Elijah McClain, Jamie Britt, they're restrained prone on the ground. Their fight or flight sympathetic surge is keeping them breathing and alive, allowing them to have an adequate tidal volume, minute ventilation, right, where they're getting enough oxygenation and blowing off CO2 to ensure that they don't become profoundly acidotic. Ketamine obliterates that sympathetic surge, right? It sedates them enough that their breathing slows, their tidal volume decreases. Held on the ground, they become profoundly more hypoxic and acidotic and eventually tip over into cardiac arrest. And these cardiac arrests are such that once they go into cardiac arrest, getting them back in a way that yields neurologically intact survival is very difficult. So I told you we don't have many answers. One answer we for sure have, and is a take-home message, is prone positioning for an extended period of time is inherently dangerous. This is especially true with a near weight on the patient's back or side, hands secured behind their back, or alcohol or drugs on board. Don't get me wrong, prone positioning is occasionally used by law enforcement, by us when we're trying to gain control, and it's an acceptable technique for gaining control. The danger lies in the decision to keep the patient in that position once immediate control has been established. We're working on this from an EMS side. The police are also actively trying to figure out how to manage patients in a safer way. I had the honor to participate in a program sponsored by the Police Executive Research Forum, where there's a national police organization that came out with new guidelines recently. And they also recognize that prone restraint carries potential risks and should be limited. They've built a series of guidelines that are getting implemented now across the country that parallel the advice that we're trying to pursue here in EMS to say, look, you might need to get somebody in the prone position very briefly, but keeping them there is dangerous. Once they're handcuffed, get them out of that position and get them up in the lateral recumbent position as quickly as you possibly can. So the summary here is excited delirium as a cause of death in custody is largely a myth. Prone restraint is inherently dangerous. Death in custody is primarily due to positional asphyxia due to prone restraint. When administered to patients in the prone position who are profoundly hypoxic and acidotic, sedation can rapidly lead to cardiac arrest. I want to take just a couple more minutes and talk to you, if that's what's actually going on, what can we do differently? Some of which, having had conversations with you here, you're already doing in Montgomery County with the leadership from an operational perspective and medical direction perspective. And our goal, I think, here today is to highlight some of the positive changes you've made and to talk about how we can take it a step further to keep patients and providers safe. So let's talk first about physical restraint. I'm going to give you my top 10 key principles for enhancing safety. The first one's going to be no surprise. Prone restraint is inherently dangerous. Never restrain, and I don't use that word lightly, in the prone position for an extended period of time. Death can occur suddenly and with little warning. It's critically important as EMS providers that we continue to see these individuals when we show up as patients, not suspects. We're working with our law enforcement colleagues. It's natural to see the individual that they're struggling to restrain through a law enforcement lens because these are our colleagues we work closely with, but it's critically important we keep focus on the fact this is a medical patient. People sometimes push back and say, well, Eric, when I showed up, the police were wrestling with this guy. We asked them to turn the guy over to us, but we were waiting for the patient to be turned over to us so we could get in there. Nope, I'm sorry, guys, that's not the way it works. When you show up on scene, you step off that piece of apparatus, that individual is your patient. They may still be in police custody. Both things can be true at the same time. And our job, working in cooperation with law enforcement, is to intercede to and try and keep that patient safe. Not to interfere with their job, right? They've got a job to do in obtaining control, but our job is really to get in there and say, hey, I'm worried about him. Can we get him up on his side? Can I get a better look at him? I'm worried about his breathing. De-escalation is worth the time. I think if we come to understand the risks of physical restraint and chemical sedation, we recognize that even when we've got a very agitated patient who maybe I would have approached before and said, hey, I think we need to sedate this guy, maybe now I'm going to invest a little more heavily in de-escalation because I recognize that that's a better approach if I can get it to work. And I've been surprised by the number of senior EMS providers who have looked at me and said, Eric, you'd be surprised. Some of these guys who you think are completely out of control that you're going to have to sedate, actually sometimes you approach them the right way, you can get them de-escalated. I can't breathe. On so many of these videos I've watched, literally the last thing the patient says is, I can't breathe. Don't get me wrong. Will some individuals use this as a ploy to get out of restraint and say, hey, I can't breathe, let me up? For sure. But I think what we've learned from these videos is we can't take that chance. If they say I can't breathe, the only option is to believe them and reposition them so they can oxygenate and ventilate effectively. If you can speak, you can breathe. We sometimes say this. I've said it to patients on scene. Law enforcement sometimes says this to someone who says, I can't breathe. Turns out it actually is a myth. Speaking only requires moving a small amount of air past the vocal cords, nowhere near a sufficient amount of tidal volume to oxygenate and ventilate effectively. And interestingly, in the PERF guidelines that I mentioned earlier, we specifically call this out as a myth because it's something baked into the culture of EMS and law enforcement, and we want to get the message out there that it's not true. Number 8, move them to supine or seated position ASAP. get them out of that prone position, get them out of the lateral position. And if they're going on your stretcher, they darn well better be in that supine or seated position. Number 9, never place a patient on the stretcher prone or with handcuffs behind the back. I think there's a great example where, as you've explained to me already, this is something that Montgomery County makes very clear, that even if the police have handcuffed them appropriately behind the back, when they are transitioned to the stretcher, those handcuffs should come off. And then number 10, obese patients are at increased risk of apnea. We heard Mr. Britt trying to breathe when he was lying prone on the ground before he was even sedated, and you could hear his sonorous breathing, in part due to that large pannus pushing up on his diaphragm and impeding his respirations. And the last couple minutes before we get to the talk, I want to talk briefly about how we should be approaching chemical sedation. How? We should approach it the same way we do rapid sequence intubation or procedural sedation in a hospital, with procedural and clinical safeguards built in and backup plans ready to go. Quick top 10 tips. Number 1, chemical sedation is a deliberate procedure, not a med administration. Please, I know it's emergent. I know the guy's out of control. But we need to approach it deliberately if we want to keep that patient safe and keep our provider safe. That's Alex Honnold in that picture right now. Right there, climbing El Cap without any ropes. And he did not just approach the mountain and decide one day to climb up it. He climbed it somewhere between 300 and 400 times using ropes, planning out every single move before he dropped the ropes to the side and climbed it without the use of any backup. Number 2, only proceed with chemical sedation if the patient is an active threat to self or others. I think there's another area where Montgomery County is leading the charge in terms of changing up your protocols. Chemical sedation is really only intended for that patient who is actively a threat. And by actively, I mean at the time you move forward with chemical sedation, they are in a position where if we don't sedate them, they're going to harm themselves or others. Number 3, beware unconscious and anchoring bias. This could be a whole separate conversation in of itself. The bottom line is when we show up at a highly charged, stressful situation where we have an agitated patient, those are the situations in which our unconscious biases and anchoring biases. So anchoring bias might be the police might have said to us, hey, we think this guy's on something. We then make the assumption that he's on a stimulant drug. If we're making the decision to administer a powerful sedative, then we darn well have better done our own assessment and confirm the information we're being given. How do you fight back against those biases that we know can impact us in stressful situations? I wish I had better advice. Slow down, be systematic is a good way to approach it. Use a checklist kind of approach, as we'll see. Have, where possible, a duty officer, an independent observer who can help ensure that motions are in check. Number 4, before proceeding, identify and treat any potential organic causes. Is this guy agitated because he's hypoglycemic? Is he hypoxic? Did someone hit him in the head with a hammer? Before assuming what we think we know is going on, it's important for us to conduct a thorough evaluation. Number 5, select the medication based on the patient's presentation. You have available to you in your kit, is my understanding, ketamine and droperidol. And those are different drugs that should be used for different situations. Ketamine, in my mind, is really intended for the patient that's severely agitated where you need to obtain control quickly. Droperidol, great drug. It's been introduced in a lot of EMS agencies across the country. It does take a little bit longer to kick in. So great drug for a moderately agitated patient, but you have to be comfortable with the slower onset that you get with droperidol. Never, and again, I don't use that word lightly, never administer chemical sedation to a patient in the prone position. It carries a high risk of death. You have to reposition them first. In RSI, we say resuscitate before you intubate. Here, we should say reposition before you sedate. Make sure that patient's positioned in a way they can breathe. Where possible, a supervisor or independent paramedic should be present. Here's where the rubber really meets the road. All monitoring and resus equipment must be at the patient's side before proceeding. Did you see in the video with Jamie Brett that all of their equipment wasn't that far away? It was right over there in the ambulance. When he all of a sudden became apneic, of course you can run back to the ambulance and grab a BVM. Of course you can rush him over. It's the wrong way to do it. You need to have the monitor equipment next to the patient at the time you begin the sedation procedure. You need to have the resuscitation equipment at the patient's side before you begin. Before proceeding, ensure the team has a shared mental model and has been briefed on plans B, C, and D. I'm pretty sure this is going to go smoothly. We're going to give them some ketamine. He's going to calm right down. But I need to let you know, every once in a while, these folks do become apneic, or their breathing slows, or their pressure drops. And what I want to do before we go forward is make sure we've got everything in place to deal with those eventualities. Where possible, have a timeout before proceeding. If I'm the paramedic leading this, I want to brief the team and make sure that they understand what the plan is. And then during sedation, the provider must be laser focused on monitoring the patient's airway, breathing, and circulation. I often have people say to me, "Oh, Eric, I get it. Once we sedate them, we need to do post-sedation monitoring." I'll be honest, I hate that phrase. I think the right phrase is peri-sedation monitoring and care. That implies that when we're administering the drug, we're already monitoring the patient. This is already someone who's sick. He's hypoxic, acidotic, may have alcohol on board, may have stimulant drugs. We may not know what he has on board. We likely don't know. So assuming that we only need to begin monitoring after we sedate is a mistake, I think, because in many of these videos, we see them move to get the patient on a monitor rapidly after they've given sedation, and it's already too late. And then I just want to close by noting that I've talked with a lot of paramedics that have seen near misses where patients have become apneic and been fortunately resuscitated successfully. But it typically is when you have a patient with alcohol or other sedative drugs on board, and we add additional sedation into that mix, trying to gain control, that you see these patients suddenly and quickly become apneic and need rescue. All right, that's the introduction. Let's turn it back over to the conversation.
No, that was great, Eric. Thanks. That was a very all-encompassing presentation. I think it gave us a really good overview of the potential issue and some of the things that we're already doing to help prevent that. Chief, did you have any questions in the chat that were related to the presentation before we move forward? Okay. So yeah, I think it's a great time to just have some open conversation about it. So from my perspective, again, full disclosure, as the only BLS provider at the table, everybody else has a higher level of medical training than I do, but I think a lot of this is about first recognition, right? If the main problem is prolonged, prone restraint, right, and we know we can reverse that, well, anybody can recognize that, right, and help reverse that. So I think as an organization, no matter what the call type is, whether it's a fire call or an EMS call, when it gets dispatched for one thing and we arrive to find that same situation, we're kind of mentally prepared for that, right? It kind of goes into that, it's almost a bias, right? Where you're plan confirmation bias, whatever you want to call it, right? Where you get, okay, this is what I'm going for, this is what I found, everything goes smooth, right? So we know sometimes when calls come in through a third party, whether it's law enforcement or whatever, it doesn't have the ability to be EMD'd like a normal call would from a first party caller. So we don't necessarily know, right? We get dispatched for a BLS sick person, let's say, with the police, right? A BLS ambulance goes, single unit resource. Recognizing this, hey, this might be have the potential to escalate into one of these things, getting the appropriate resources on the way. Whereas opposed to if we can talk to the EMS duty officer perspective about this, but if you get dispatched to an agitated patient response where it's a manpower piece with an ALS provider, a transport unit, an EMS duty officer, you have a different frame of mind and you might be in tune to look at these things. So I guess, Jan, do you want to just talk about real quick from your role as an EMS duty officer? Do you want to do this question now? Sorry, so we have a question. You want to ask it right now? Go ahead. Before we do that, we have a question.
Yes, so these situations may be managed effectively in some part by crew resource management. Along those lines, are there certain words or phrases that can be shared with both our crews and with the law enforcement?
So I think a lot of what we've been talking about is crew resource management, right? I mean, crew resource management is about not losing the forest for the trees. And I think what you heard me demo, and we're going to see in some of the clips we have prepared for you guys, is exactly that. Where the paramedic is, and I don't know if there are any magic words, but I think it's articulating out loud what we're doing and making sure we have that shared mental model with the team and making sure we're fully prepared. And I do think, yes, making sure we're carefully integrated with the police. I didn't share it with you, but recommendations from both the EMS side and from the law enforcement side talk about the need for law enforcement and EMS medical direction and leadership to meet ahead of time and talk about how we coordinate these events. From a police perspective, excited delirium was often how these events were described, and now we see a shift in language. Sometimes they're being called medical behavioral emergencies. Sometimes there's other phrases that are being used, but we need to meet with them ahead of time and make sure that we're coordinating our efforts so that things go smoothly. We had the opportunity to talk yesterday with some law enforcement folks here from Montgomery County. They're doing some very progressive things around avoiding prone restraint with individuals who they may be subject to arrest, or where they may be helping us with a psychiatric or medical emergency. But I think crew resource management and ensuring we all know what we're saying by discussing it out loud. I think sometimes I see EMS crews that have worked together for a long period of time that can almost read one another's thoughts, and that's really cool. But I think we're now at a point where not just on these emergencies, but other high-stress emergencies, we're articulating out loud what we're thinking, especially if we're in the leadership role on that team, so that the entire team knows exactly what we're doing is critical to maintaining safety for that patient and for us as providers.
So somebody asked about words and phrases. I think that the number one point of view is to keep it medical. Okay, not medical in the sense I'm going to put out big words. Okay, is that better? Medical terms, not again to be speaking big terms that are incomprehensible. No, layman's term, but medical as in the context of what we're talking about. First thing we have to do in a situation like this, I think, is try to bridge the gaps, because we have two entities, ours and police, and we have a very different point of view of the situation. One side is looking at making things safe, and they are worried about us, they're worried about themselves, they're worried about the patient as well, and one side is trying to come in and figure out what is happening and what is expected of me. And depending how many resources you have there, things can be different. I mean, I do feel bad for the single resource that is there, especially junior guys that may be on an ambulance or on a medic unit by themselves, where they feel the pressure of a situation like this where, oh, I'm expected to make this person more compliant so the cops are safe, so I am safe, so I can take him to the hospital. Taking a step back, doing a full assessment and trying to understand why is this patient in the situation in which they are now is the first step. And we've gotten into a habit over time of rushing that steps, and I think it's the first place to slow down is, hold on, I get what the scene is, but let me get a picture of what is going on. Let me talk to the patient and try to see. And you're right, a patient that says, I can't breathe, I have a duty to try to do something about that. And then it becomes a gray area when you try to reposition them and sit them and they try to fight you. And now this is a whole escalation, and we have to work with the police, and prone may temporarily be a situation that happens even if we don't want it. I think there's more gray areas than certainties, but I think communication, and for us to stick to our guns of all I'm trying to do is make it safe for this patient to be transported to where it needs to be transported. That should be our primary goal. And we tend to rush through that a little bit.
Yeah, and from a field provider perspective too, I think the moral of the story is don't be afraid to ask for help, right? It's just like if you do get that general impression, that initial size up, right? If I go for a fire alarm and I find fire coming from the building, I'm gonna ask for a box alarm, right? If I get somewhere and I get the general impression and do that initial assessment and find that this person is in this state, call for help, right? You have the EMS duty officers as resources, both on the radio and in person, to call for them. We have ample ALS out in the field, so if you need help, call for it, right? It's your support system.
100%, the more the merrier.
I would also seize on what the point you were making, Jan, about medicalizing the problem. The question was, what do we do besides crew resource management? And we all know internally what the tenets of crew resource management, and certainly the longer we've been in the department with the more and more training in CRM, we understand the concept when it comes to dealing with each other. But the question is very excellent, very cogent in that this is a cross-agency question about CRM. And although I agree that sometimes there may not be individual words that everyone must use, I frequently tell dispatchers who are trying to clarify questions within EMD that they have a certain way of doing it that's within the guidelines. So although there may not be a magic word, police, I think, look to us to be the medical experts, and they're very willing, and especially in a progressive department like here in Montgomery County, they're very willing to take messages about our concerns that it's a medical issue, and then acquiesce or cooperate with us on making medical situations better. So using CRM cross-agency with the police, the issue of medicalizing the problem, I think, is the key issue. Find a way of saying, hey, I'm worried about the patient's breathing, or I'm worried about this medical issue, and that's what I'm trying to work with you to mitigate. The other thing is, for our own edification, if you look at the film clips about Mr. Britt, you talked about the sonorous respirations. If you see his back was just covered with sweat, so he was sympathetic discharge, and BLS clearly can pick up on that. If we put our own selves in the mindset that a certain significant percentage of those patients are potentially clinically unstable, and we've all been educated about the clinically unstable patient and the need to anticipate the peri-arrest or peri-code. If we look at a patient like that and we already know as an agency there's some clues there that may be associated with cardiac arrest, foresight, that really does help ramp up our next steps towards some of the tenets that you've described. So medicalizing the problem, recognizing the potential clinically unstable patient. So this area of topic is really a sub-area of what we've been talking about a lot with respect to other medical problems in the clinically unstable patient.
And I wanted to add one thing regarding medicalizing it. Let's be honest about the problem first. Take any person, I can take anyone in this room right now and put them through a 3-minute struggle with the cop, handcuff them in their back, and they're going to be struggling to breathe and they're going to be begged to be let out. It's not a bad guy reaction. It's a normal human being reaction at this point where you're lacking air, you're lacking freedom. Those things are putting you in fight or flight, and you are all in onto this. There is nothing, oh, calm down, please. That's not going to do it. If we want them to calm down, we're going to have to change the situation around them to give them a chance to calm down. If we don't do that, we cannot expect them to calm down. Right. That is not happening.
Yeah, I think Chief Light had a question from the chat too, but just along those lines real quick, I think it's important, a good time to note, right, we're talking a lot about police interactions, but these things can present, it doesn't have to be a law enforcement interaction, right? This could be bystander restraint of somebody, it could be some kind of physical altercation between two citizens, it could be security at an establishment, whatever it is. It doesn't have to be you're arriving to someone restrained by law enforcement to be able to recognize these signs. Chief, do you have something related to what we were just talking about?
Well, we have another question.
Okay.
So whenever you're finished this one, we can get to it.
Okay. Did you have something on this one, Eric, on this topic?
No, I think I just want to reinforce what Jan said, that I've watched many of these videos where they're struggling, they're trying to get up. They're not trying to get up to go at it with the police or with EMS. They're trying to get up because they can't breathe.
Go ahead, Chief.
All right, so the next question. In terms of requesting sedation to be able to properly assess a patient, does that fall under the category of harm to self if they're not allowing that, agitation, violence, etc.?
I'll take a crack at maybe it depends might be the answer to the question as posed, but I think what the individual is asking is if a patient is exhibiting a degree of resistance to the medical care so that you can't assess them in the first place, does that constitute a danger to self or others? And I think that and I would invite others to chime in. I think that just like any other patient presentation of agitation, it can be milder, moderate, or severe. So part of one of the reasons that we advocated for keeping ketamine on the formulary is because we think when used correctly in severe forms of agitation, it can potentially be life-saving in that it allows the assessment that we need to be ready for the potential peri-arrest situation or the unstable situation. So the answer to that question would be yes. If the type of agitation falls under severe agitation, even if you don't think the patient will attack you, if the patient is so agitated such that you can't get them controlled to assess them, to save them, then yes, I believe that would be a judgment call of when that constitutes danger to self or others. And that is something that MIMS has allowed us to act on without having to call in for medical oversight based on this 2020 memo where they said the patient should be very severely agitated to use the ketamine. So I think the answer to that question, it depends on the spectrum of agitation that you're dealing with after, whether the person's amenable to de-escalation and other techniques before you have to sedate them. Is that?
Yeah, I would add that there is a timeline, or time is a factor. Right. You show up on the scene and you have somebody who is really literally cannot stop trying to bite or spit or just go after everybody around, and law enforcement is really doing their best and they can barely manage the patient. we're definitely going to have to go for the bigger, going faster. It's obvious that that person is not going to be able to be controlled in a safe manner, and therefore we're going to have to pull out the ketamine. But there was also times when, and I have seen it with our law enforcement around here, where the patient is not quite at that level, and we can take a little bit of time to slow down, to assess. And I have seen it here with our law enforcement, where before our provider even had to do something, they were able to de-escalate the patient, where we were maybe in a gray area between the moderate and the severe, and now we are definitely in the moderate, where we have time where we can work with our partner agency and the patient and have a happy resolve.
I was wondering if, at the street level, whether this is a common thing that you or your colleagues have faced in terms of, along the lines of the question in the chat, you have a patient who's not letting you touch them, and you're really worried about the fact that they need that assessment as part of the life saving, therefore it constitutes severe agitation.
Now, when the question was asked, I just thought, yes, yeah, you need to sedate that patient. So I didn't go quite as deep as what you all did. I heard yes in my head. I just sort of felt like if you're not able to obtain vitally important information and it is an agitated situation, you're sort of at that point where you would be within the protocol, not in a position that you had to consult. You go ahead and treat the patient, move on. So
I think it's a great point, Andrew, that that is how it works in practice. But I want to clarify one thing when we talk about assessment. We love to be able to get our monitor onto the patient with the pulse oximeter, the electrodes for an EKG. But we walk up on a patient who's agitated. I get it. You can't put a pulse oximeter on them. You can't get electrodes on them because they're struggling. Doesn't mean you can't assess your patient. You can still assess the situation. Hey, does anybody know this guy? Do we have medical history in this guy? Do we know what medications he takes? Is he allergic to any meds? You noted in the James Britt video they gave the ketamine, then they asked the questions. That's not the way EMS works. We conduct that assessment ahead of time. And I get some of these folks are very agitated, and we're often under considerable pressure to move forward. And we can definitely move expeditiously, but that doesn't mean we move precipitously. You do what assessment you can. I walk up. I might not be able to get Jan on the monitor, but I can reach over and reach down and check his pulse. I can look at his skin signs. I can look at his breathing. I can listen to his breathing. And if I'm any good as an EMS provider, I can do a fair amount of assessment without ever getting the piece of technology connected up to the patient. So it's critically important. Let me say one other thing. I don't want any of this to come across as opposed to ketamine or as opposed to the use of sedation when it's needed. I think ketamine is a great drug, and I think we definitely encounter patients that are so agitated and out of control, as Jan accurately described, that they need to be sedated, and we need to do it, and again, I'll say expeditiously, not precipitously. I think the key with ketamine, and I think what's occasionally gotten into some of our colleagues into trouble, is ketamine does what we're asking it to do extremely quickly. In the old days, when we had a benzo or we had droperidol, they worked, but they took some time to kick in, and if we weren't immediately on board with our monitoring, if we weren't paying complete attention, that's okay, because it's going to take them a while to become sedated for their breathing to slow. Ketamine works like that. It does exactly what we're asking it to do. It helps us gain quick control. It's a safe drug, and you can dose it in fairly large doses safely, but you need to be ready to go from the moment you give the sedation, because that's where I've seen paramedics get into trouble.
Can I just say one thing? So in that video, you saw the gentleman laying on the ground. He's saying, the only thing you hear him say is, I'm not going to hurt anybody, I'm not going to hurt anybody. He's not actually talking to the paramedics. They rolled up in there. Part of our severe agitation, I believe it says, is irrational behavior. So if I cannot have that sort of assessment conversation, and then I see them administering that, the thing they didn't do is a good job planning for it and being prepared for it. Again, not judging them, but just saying, like, if you're looking in lessons that they could have taken, what I feel like they did though is, once he started calming down, then they were on it. Hey man, you got any allergies? And then he actually started, as seemed like he was calming down. Just a slight aside that I thought I saw. So
yeah, I think when you watch that video, and again, there's no right or wrong answer here, and as you said, we're not judging these individuals. I have to ask the question, if they could ask him those questions, couldn't they have asked those questions before they proceed with the ketamine?
Fair point.
And if they could have that rational conversation with him and he's shackled and on the ground, is he at that moment an active threat to himself or others that you would have decided you really need to? And it might be that he needed to be sedated, but hey, how about we roll him up on his side first? Hey, let's get him up on the stretcher. Can I have a shot at talking to him? I wonder if I could get him calmed down. Might not have worked. I don't want to be Pollyanna about the magical powers of de-escalation, but I think we need to give those a shot, and we need to conduct whatever assessment we can. If he's talking gibberish to me, I'm going to look at his wife or his brother. I'm going to see if I grab his wallet and look in there for a list of medications, right, or any sort of card to give me any sort of heads up. And again, I'm doing all this in the space of a couple of minutes as I get set up to proceed with sedation, because I'm thinking that's probably what's going to need to happen here. But I'm the whole time asking myself, and I'll be honest with you, I've given kudos to some medics who came into a situation assuming they were going to need to sedate, got the meds pulled up and ready to go, but then decided at the last minute, hey, let's hold off because it's not clear to me at this point that sedation is still indicated. He's calmed down enough that I think I can have a conversation with him. So
I think that's a great segue in the spectrum you just described, from de-escalation to making sure that you assure that the patient's out of the prone position, and then chemical sedation as a deliberate procedure. This might be the perfect time to actually go into the vignettes that talk about these tenets specifically.
Yeah, I think we're about halfway through. So for those who don't know, we have some scenarios that were pre-filmed that are prepared that I think will also lead to some really good discussion points. So yeah, if you want to, Eric, you want to segue into those, I think they'll also spur some good conversation.
Yeah, so we filmed a few scenarios earlier today, and why don't we just jump in with scenario number one? I think the goal here is you're going to see the crew encounter somebody in prone restraint and watch the manage.
And also, speaking to Captain Michaela's point, it's not necessarily about a law enforcement scenario, so you'll see that when you look at that.
Awesome. All right, we want video one, correct?
You stay right there, okay? Buddy, you're going to be okay.
Hey, guys.
Hey, glad that you're here.
Hey, what's going on here?
Hey, this guy's completely out of control.
Okay.
And he hurt some of the staff.
Hey, bud.
We had to give him a shot to get him calmed down.
All right, can we get him on his back?
He's staying right there where we got him.
No,
He hurt some of the staff. When the cops get here, we can get him up.
I understand we're worried about his airway like this, so we got to figure out a way to get him over, just so we can protect him and we can assess him better, okay?
Yeah, I think it'd be best if he stayed right here until the cops get here.
I certainly understand that. We can assist you, and we can get some other people to help if we need to, but we do have to get him over. It's critical. We absolutely have to.
Fine.
However we do that, that's what we got to do. Easy, sir. Hey, we're going to take real good care of you, buddy. What's his name?
John Smith.
John, we're going to roll you over, okay? Please don't fight us. We're going to help you out here, okay? My name is Andrew. I'm here to help. All right, guys, we're going to roll him. We got to get him over.
Get him up on the side?
On the count of three.
Which way to roll him?
We're going to go that way.
Okay.
Log roll, and we're going to control his arms. I'm going to hand this arm to you, and I'll take that one. Ready? 1, 2, 3. Easy, John. Good job, buddy. Good job.
Hey, John.
All right, let's take a look. Hey, John, look at me, pal. How you doing, bud? All right, we're going to get you on our monitor and just get you checked out. Are you okay to set like this?
Who are you? We had to give him some Droperidol.
Oh, you gave him Droperidol?
Yeah.
Okay, yeah, no, we definitely got to monitor this gentleman. We got to get him on our cot.
Okay.
Get him on.
I'm gonna sleep.
Get some form of monitoring going. Can we get the stretcher? I think he's actually doing okay. We want to get him on the stretcher in that way. Hey, Bob, we're going to get you on our stretcher so we can get some monitoring gear on you. Are you doing okay?
Guys.
Can you tell me your name, bud?
John.
Hey, John. You know where you are, John?
This place. Can I sleep on that thing?
Yes, John, you can relax on this thing here in just a second, buddy. Do you think if I assist you up, can we get you in the seating position? Are you able to help us at all, John?
I need help.
You seem like you're doing okay. Are you guys okay with that?
Yeah.
John, let's roll you up here on your... Are you doing okay, bud? What if I stand you up? Can you just stand up and sit on my stretcher for me?
I don't know.
Are you able to assist me?
I might be able to
Come on, bud.
get my feet under.
Come on, let's go. There you go, John. John, you're doing great, buddy. I really appreciate it. I know you're having a tough day, but we got you. We need to use all our straps, guys. for safety.
Is it Monday? It feels like a Monday.
All right, and as soon as we can get him squared away, I want to get some monitoring gear.
Okay, sounds good, yep.
All right, John, you ready? We're gonna wheel you out, bud.
Okay.
Well, kudos to our Montgomery County paramedic acting team there that did a phenomenal job. I want to start out by saying that.
We might get an Oscar yet.
Absolutely.
I wasn't involved, but they might get an Oscar.
I would put in a little plug for the OSCE family, where we use actors all the time. So this is a acting school, the OSCE for this.
So Eric, do you want to describe what they encountered and some best practices that were initiated to have a positive outcome?
Yeah. So these guys showed up at a psychiatric facility where a patient had gotten out of control, and the staff, and it hurt some staff, and the staff had taken him down in the prone position, trying to gain control, and had given some droperidol on scene. And our paramedic came in, and as soon as he saw the patient in the prone position, noted that he wasn't fully alert, he elected to step in and at first step say, hey, we got to get him up on his side. I'm worried about his breathing. And that's it. Whether we're dealing with law enforcement, dealing with hotel security, dealing with a psychiatric staff, the recognition of that prone position, especially if a sedative has been administered, is particularly dangerous. We got to get them up into that recovery position and check on them. And it's interesting, since we've started doing this work, I've had multiple agencies come back to me and say that just helping providers understand the need to intervene here, and it can be challenging if you're a brandy new paramedic with a shiny gold patch and you weigh 140 pounds and you come in the door and there are a bunch of burly guys who are really worked up, holding somebody down who's been a jerk and punched some people out, right? Intervening in that circumstance can be challenging. What we saw them demonstrate here is exactly why that needs to happen professionally. Hey, we need to get him up. No, he's staying right where he is until the cops get here. I really need to get him up on his side so I can conduct an assessment. So exactly the way we want.
It's about that balancing act, right, between provider safety, patient safety, positive outcome on the call, right? And that's something that you can't teach, right? You know, this type of call gets dispatched. Well, how's it dispatched? Is it you get dispatched at a psychiatric facility with a possible combative patient? We ask, are there any scene security issues? Well, it's unclear, you know, are the police there? Are they not there? Are there call notes that the person is struggling to breathe? And you're unclear whether the scene is actually safe or secure. Like, there's not answers to all these questions, and we have to balance all those things, but it's definitely really good food for thought.
Can I think you mentioned something really important that we need to make super clear. Our safety and the safety of our colleagues is always our highest priority, and no one is asking anybody to do anything here that puts their own safety at risk. The courts on this particular point have been extremely clear that it's appropriate for us to ensure that our safety is a high priority. So you're absolutely right. If you show up at a scene and it's an unsafe scene, then we shouldn't enter it, and it is law enforcement role to secure that scene before we enter it to make it safe. And unfortunately, that sometimes means we're going to encounter a patient who's suffered some amount of deterioration. But the first job is to keep us safe when we come in the door. That has to be our highest priority. And then as soon as the scene is safe, we'll step in and provide patient care.
Can I just add one thing about identification of that? Wouldn't necessarily be an ALS skill. It's an everybody skill. So that's...
Absolutely.
One other small detail I think is worthy of note. It speaks to the tenets that you described in your slide set about fresh set of eyes on what the current status of the patient is. One of the things you did very well as an actor in that case is you showed the bias that you had of what he had been acting like before, and that was why you were reticent to let him up. But the paramedic in the scenario, because they were practicing the fresh set of eyes and assessment from their medical standpoint, that at that moment of in time there may have been something physiological, medical going on in terms of the potential for hypoxemia. And whereas in other scenarios, in this case it happened to be partially because droperidol had already been given, but it could be because the patient's just hypoxic in a law enforcement scenario. So if you were to take advice, look, this person was tearing up the place, you're seeing that, and in the case of Elijah McClain and others, they were given the sedative anyway at that time. This really underscores the fresh set of eyes. You know, what is the patient doing right then and there, and why? In this case, droperidol was probably a factor, but in another case, you're going to have a patient who's been prone a while, and they're now losing their level of consciousness because of hypoxemia. So it's important to point that out. And then
Excellent
and
point.
BLS can also recognize that potential when they're educated about this topic in general.
And BLS needs to, right? So if you run that call as a BLS provider and you recognize that the physician on scene or whoever it is has already initiated that chemical sedation or whatever, you are not going to be able to monitor that person or potentially provide the appropriate interventions by yourself, and you need to initiate that ALS response too.
And I'll add, because we've experienced that as ALS providers, and we still experience that all the time. The number of times BLS providers have saved their bacon on call. And so even if it's an ALS call and paramedics are hard at work, please, don't stop looking for those signs. Don't stop looking for those things that we may be at that time missing, because we get tunnel vision like everybody else. We're working on a patient. This is a weird case. It's not something we run every day. So, yeah, if somebody in the background can be, hey, would you like me to do this, or would you like me to get you that? That can be extremely powerful, because it saves us, having to walk away from the patient, or maybe even realizing something we never realized in the first place.
Right, particularly if there's one ALS set of eyes on scene only, right, and you're focused on a procedure, let's say, it's easy to, lose sight of that big picture, because rightfully so, you're focused on your current procedure. So, excellent.
So is this a good segue into the de-escalation piece?
I think it is. I think we're ready for our next clip. So what we're going to see in the next clip is a patient that is intoxicated, is out of control. Family member is called to ask for our help. We show up on scene, and I think the setup for this clip is we might have come into this scenario, seen this patient, and thought, hey, we need to get the chemicals. Can you go back to the truck? Let's get the we're going to have to sedate this guy. And yet what you're going to see the crew do is come in and engage with the patient and recognize they may be able to get this guy de-escalated. Chemical sedation may not be necessary. And again, I don't want anybody to shy away from it where it clearly is clinically indicated. The concept, though, is that we recognize the risks inherent in chemical sedation. If we can get de-escalation to work, it's worth investing that time. And fascinatingly, as I go around the country talking about this, I've had multiple senior providers come up to me and say, Eric, some of those scenarios you're setting up, I would have invested more time in trying to make the de-escalation work. So let's see the clip, and then we can talk about it more afterward.
Hey, George.
What?
Give me the drink.
I'm enjoying it.
You gotta stop drinking, man. You've been I've been here for 3 days.
This is water.
It's 3 days. It's not.
It's water.
You smell the bourbon, right?
No,
If
no.
water,
It's just
you're
really
going to
cheap
rehab
bourbon.
tonight.
It's basically water.
I got your text message, right? I can't let you do that to yourself. You put the car in the garage and
Knock,
you
knock.
know,
Fire
Dude, that
rescue.
car's falling apart. No.
no, what you're gonna do with it, right?
Hey guys, fire
Right.
rescue.
Hey,
Wait, did you call them?
Yeah.
Why'd
I called
you-
them. Well, you need some help. You
No.
can rehab.
No,
Now you
no,
need to mess with the carpet. Just stay,
No.
George.
I don't want to.
George.
Who is he?
Hey guys.
Did you call him?
Hey,
Yeah,
what's
we
going
called
on
for some
today?
help.
Why?
You're going to rehab tonight, and I don't care if the cops have to put you in protective custody. You're going.
What? No.
Yeah, you lost your
No,
job.
you're not my
Your
supervisor. You're not my dad.
I'm your big
No.
brother.
Can I talk to you for a
Hey,
sec?
just watch him.
What's
He is-
going on?
well, he's
You're
had
a
a
big
ton of
blue
drink.
boob of a big brother.
Oh man, I'm trying to be patient with you.
Tell me what's going
CBD, a lot of drugs. He texted me, said he was going to kill himself tonight by
So we're worried
by
about-
shutting. Look, hey, we're gonna no.
Hey,
Where did you come from?
The firehouse right down the street, George. My name's Andrew, by the way. Your brother.
I don't care what your
brother.
name is.
Hey, you're going tonight, and they're let him help you because the
So
next
here,
stop
if you
is
can
what?
just let me just talk to him super quick, if you don't mind. Hey, George. Sounds like your brother's a little bit worried about you. He's worried that maybe you made some
My
some
brother's
statements.
an idiot.
I'm
He
so
doesn't know
sorry
what
about
he's
that.
talking about.
Yeah, so we're here to help you. Are you feeling like you're trying to hurt yourself, or are you?
I'm
are you
feeling
worried?
parched.
Feeling parched.
I'm thirsty.
Sure. He said you'd been having some drinks this
He
evening.
threw it was water.
Okay.
There was just water in that cup.
Okay.
He said it was bourbon. It was not.
Yeah.
It was.
Do you mind if we
Water.
get you checked out? We'll just do some vitals and
No.
just see how you are physically,
No.
your health and
I
everything.
mean, where did you?
He called
Why
out
did
of
you call
concern.
these people?
Yeah, so he just called out of concern. We're just here to try to help.
No,
I'm
no,
so
no.
sorry. you're having
He
a
thinks
tough
he
day.
can. He thinks he can control me. He can't, and you can't either.
Well, I'm
No.
not trying to control you. I'm literally just here to check
could've
you out.
fooled me.
This is just for health, sir. Do you want to have a seat? I'll just put you on the monitor real
if
quick.
I wanted to sit down, I would have sat down already.
Sure, I understand. Well, let me
Do
go
you
talk.
understand?
I'm gonna go ask for a little bit more information. My partner here, they're gonna talk to you a little bit. Just be as calm as you can. I'll be right back.
Hey,
Who are
George.
you guys?
I'm Mary. This is one of our other partners.
Shit. Whatever. Stupid name.
Tell me what's going on today, George.
Look, my brother he thinks he's my dad or something. He doesn't, I just want to live my life the way I want to live it, and he can't say anything about it.
I understand that, yep. Is there anything else that happened today?
No, nothing that I want to talk about. And definitely not with you guys. No.
What's been going on?
Look, I like drinking, okay? And there's other stuff going on, and I don't want to be aware of those things. So I'm not.
Okay.
And that's the way I want it.
There's some people that care about you that want to get you some help.
No, they care about themselves.
No, I think they're concerned about you with some of the things that have been going on. And we're here to help too.
Is he out of here? Did he leave?
Yes, he's outside.
Outside. I don't want to see him again. I don't want to see him. You tell him pound sand. Just go.
Okay. We'd really like to take you over here and we can get you checked out and get you some help today, okay?
But I don't need help. What, you gonna pour me another drink? Like, what do you mean help?
No, no drinks.
You know what, wherever we're going, is he gonna be there? Not you. You're weird
We can make sure
person.
that
No, my
if you don't want
brother.
him there, we can make sure we can keep him away.
Yeah, we can keep your brother separate.
Or, fine. I just want to go.
All right, George, come with me.
You need some help?
No, I can do it.
Gotcha.
Got him?
Yeah.
Okay, good, he's gone.
All right, so I don't want to say that's a common call we run, but it is, right? I mean, not that exact scenario, but we run into situations like that all the time, right? Where you're almost a counselor, a mediator, more than you're actually providing some kind of immediate medical intervention, right?
And let's be honest, like how many of our guys run this call on a daily basis? And we never hear anything about it because they do a great job.
Yeah, and I think and it doesn't require a whole lot other than being a good person, right, to do a good job in that scenario and de-escalate the situation. So, Eric, you want to describe a little bit more about it?
No, I think you guys are exactly spot on. We run these calls all the time. A lot of our folks are really good at running these calls. But I think some of what we were trying to illustrate there is sometimes you come in the door and it's a family member who's amping up the situation and you have to pull the family member out. Sometimes it's, if you're going to a facility, it can be a staff member who's gotten into it with the patient. You need to pull them out. And sometimes I'm reasonably good at chatting with folks, but sometimes I'm just not clicking with that patient. I'm just the one amping them out. And as we saw Andrew do, I need to be prepared that maybe today you're the guy who's going to better be able to form a connection. And I think sometimes too, we're a little bit hesitant to like get down to their level, and yet the goal is to get him safely out of the room on the way to the hospital in the back of the ambulance. So it is sometimes worth, with the clip we couldn't really illustrate it, but you might be on scene 20 minutes or 30 minutes or 40 minutes trying to have that conversation, build that relationship of trust so you can get that patient on the way to the hospital without having to intervene physically, which helps no one, without having to move to chemical sedation, which perfectly appropriate if you reach the point where he's truly out of control. But in the scenario we just saw, pretty clear you should be able to de-escalate that situation and get him
I think equally as important to de-escalating the situation is not escalating the situation, right? And I mean, like you said, that can happen, whether it's switching out a provider or whatever, right? That's equally as important. I mean, Andrew, how many times have you run into that similar scenario? I mean, it's countless, right?
Quite common.
Yeah.
I think the big takeaway, if I can just reiterate, is if everybody knows that that's a long call, and if everybody has patience and is in the emotional a good spot, because we have different temperaments, we have different characteristics, and really cooler heads seem to almost always prevail on those better.
And it's easier said than done, right? We all acknowledge that, right? When you're on your 14th call and it's your third one after midnight and you're on a 48, I mean, there's tons of factors, right? Something happened to you at home. Everybody's got their own, set of things that they come to work with or whatever it is. So I acknowledge it's easier said than done, but it does work.
But if you were a betting man, you would know that trying to rush things is going to make things worse.
Just make it worse. That's exactly right.
One more thing along the lines of what I was saying before is this was another good application of the fresh set of eyes syndrome. Even though you may have been biased by running that address in the past, and maybe you have knowledge from previous shifts or other colleagues that the patient has had to be sedated in a bona fide fashion in the past, taking that time to have a fresh set of eyes, reassess the situation, and also I noticed the buffer zone that you all kept until you started to realize that maybe he wasn't as unsafe as before. both Mary and yourself kept the distance to make sure they protected themselves, and then trying out the change of person. I know that nurses have bailed docs out who weren't getting anywhere with patients. You walk out of the room and the nurses save you all the time in the ED. So.
And I was going to say, you talked, one aspect that I thought was nice when you talk about the fresh pair of eyes, it's not just different agencies, but within our own agency, within us, to be able to rotate. If you have not gotten anywhere within the last 5 minutes of talking to this patient, what makes you think that over the next 5 minutes you're going to get a positive impact? I'm not saying give up and just, but maybe it's time for you to step back and let your partner take over. Doesn't matter their training, their level, their licensure. It's about talking to the person at this point. And sometimes we know we may have to build that connection, as you're saying, which is going to take time. So just rotate people every 5 minutes and try somebody else. And during that time, go talk to the family, go gather more information, and then come back with maybe a different perspective.
Yeah, I think we've all subconsciously done some form of that, right?
No
you
doubt.
just start thinking about it. I'm like, yeah, we've done stuff like that all the time, where you step in, somebody steps out, and just through the natural course of progression, building that rapport. So we have about 20 minutes left just from a time management perspective.
Great. I think now is the time to take a look at our last clip.
Awesome.
The buildup here is this is a patient who is, again, out of control at a psychiatric facility. The crew comes in. You're going to see them attempt to de-escalate this patient, but just so everybody, we set this up with the instruction of the patient that you're not able to be de-escalated. So we specifically set this up as a situation where the crew would have to move on to chemical sedation. And what we want to do with this piece is illustrate the approach to chemical sedation where you get the job done expeditiously, but you do it being very mindful of the potential things that can go wrong. Anticipate that it's going to go well, but also anticipate those things that might go wrong. And then when they sometimes inevitably do go wrong, you're prepared. That's really the name of the game. All right, let's see the clip.
Set. I need some help in here. This guy's... Breathe. All right, look. Chill out. What is that? What is that? I need help in here, please. What is that? Down. Keep your hands up here.
Wow.
Whoa.
Hey,
guys,
what's going on, man?
If we can get a little bit of help sedating him, that would be...
Sure. Hey, Barney, what's going on?
Chill. Breathe.
Hey,
okay.
What's your name, boss?
This is George.
Hey, George.
George is bipolar, schizophrenic,
Oh,
got a lot of things going on.
Okay.
They're over there.
They're over there.
George, get over there. They're over there.
Buddy,
Take a breath.
Hey, George, are you going to able to calm down for me real quick?
Hey,
How long has this been going on?
About 2 hours.
Oh, and just know, has he ever had anything like this happen
it does.
before?
Last time we had
No spinning. No spinning. Hey, put this on.
That's why we put the mask on.
Okay, I understand.
Okay. It'd be super if we could sedate.
Has he ever had to be sedated before? Is there any way to calm him down other than?
We've tried.
Okay.
No, he is completely dissociated.
Oh, okay.
Okay, and he can't get violent.
Have you given him anything yet?
I just got here. I don't. He's losing his arms coming out. Okay.
All right.
Stop.
We can definitely help you.
Okay.
We can't just run right into that. Any allergies, any medications that you're aware of?
I'm just early. The doc.
Hey, George, any medication allergies, buddy?
Do you see?
All right, so I'm going to go get a little bit more information.
There's ants
Brian's gonna
everywhere.
go ahead and-
Nurse
They're all over
outside.
me.
Okay.
So we'll get
We call the doc. The doc's
Yep.
now calling back.
Be right back.
We have standing orders to do this, but I can't get into the.
Can I get more information on this patient, please?
Breathe, dude.
Yeah.
I know you are.
All right, it sounds like he has no medical allergies, no medications are on board. George, are you able to come with us, buddy? All right, we're
I'm
going
cool if he comes with you.
I think we are in the spot where we're probably going to have to sedate him down. Do you think? I don't know
Probably in the
if
spot.
I'm able to talk
Everything's
him
gonna be okay.
down. You want to give it a try? Does anybody want to take another shot at trying to de-escalate this and get him on the cot? Or should we start moving towards a med administration of sedation? Any thoughts?
I think settle down.
Sedation?
Yeah.
Okay. Ketamine, do we agree ketamine is the right for this patient?
Yeah.
Okay, buddy.
Okay.
Grab the stuff from the...
Yeah, so, hey, real quick, if we're gonna do ketamine and you're gonna go...
Hey, guys, come on. Would you please hurry up and help me out here? I'm not going to rip my rotator cuff on my third day at work. I just came from the staffing agency.
Yeah, we have a compromise to his airway, so that's my big
Hey,
concern here.
look at me. Look at me. Okay, I can get you out of this, but you gotta chill out. Okay, stop it.
Do you know how much you weigh, sir?
I guess he's about 200 pounds.
About 200 pounds? Do you guys agree that 200 pounds is what George looks like?
Yeah.
Looks good.
can't, then yeah, let's go ahead and get him calmed down first.
All right, buddy.
Everybody stay a safe distance from George. All right,
Okay, man.
ketamine, 200 pounds. Let's just see what that is.
So I'm guessing speed is not one of the things they teach you in middle
It is,
school?
I'm so sorry, sir, it is not. We have to be super careful with this medication here. So,
All right, I'm going to go back to school.
200 pounds, 2.2, gives him about 90 kilograms. 90 kilograms.
Gotta let go, are you going to be cool?
Times 4 per
You be cool?
kilogram. 360 is our dose.
Okay, hey.
360 times
Sir.
5
They're right there.
No, they're not.
They're right there.
Is
They're right there. Right there.
3.6 mLs per pound patient. Do you agree?
They're here.
Dose is 4 mg per kg, so 3.6 mLs. Using the high dose ketamine is 500 milligrams in 5 mLs. Do you agree?
I do agree.
Okay. And I'm taking 3.6 mLs.
Okay, fellas, anytime.
Working on it, sir.
I know. Can I have this stuff pre-drawn? Hey, quick kicking, quick kicking, quick kicking, quick kicking. Hey, I'm losing control of this over here, guys.
Sir,
Careful now.
Take a breath.
Alright, so 3.6 mLs.
Stop. Stop. Okay. Will you get on the cot with us?
Yeah.
Hey, easy.
Alright, 3.6 mLs, do you agree? You guys ready?
Hey, all right, hey, George. All right, man, chill out.
Hey, buddy.
No.
We're gonna expose.
Where are you going?
I'm gonna go. Well, I would like to go in his shoulders.
All right, I'll be. You need to hurry up.
Hey, George. Hold on there, pal. There we go. George. You're doing great, George. Yeah, long sleeve shirt. Long sleeve.
Oh, look, there's a hole.
Yeah, there's a hole right there. It's a short sleeve shirt.
Hurry up.
All right, George, easy, buddy. There you go. All right, on board.
Okay. All right, George.
All right, so what we got to do, guys, we have to monitor this patient. We're going to keep him. He's going to start to calm down at some point. Hey, George, easy, buddy. When he does calm down, we want to go ahead and transition him. Easy, George. Easy, buddy. This is going to make you calmer. Once you're calmer, we're going to go ahead and get you checked out, okay, buddy? Yep, easy, pal. If you don't mind, now that he has this medication, I want you to monitor his airway. Just keep an eye on his breathing so that I can focus on other stuff.
Okay.
Hey, Dom, I need you as a second set of eyes, and if you don't mind getting the BVM out just in case, have suction ready for me just in case. My only concern is if he stops breathing or has any respiratory compromise. Hey, George, easy, buddy, easy. Are you starting to feel better at all? At least less combative? Easy, George, easy, pal. Let me know when you have that stuff ready, and then we'll set the cot up over here. He's already starting to calm down a little bit. How's his airway?
Looks good so far.
Still breathing, right?
Still breathing.
Easy, buddy, easy. The other thing we want to do is, as soon as we get him on the cot, cardiac monitor, end tidal. Well, yeah, we just really want to get some. Hey, are you doing okay, George? Hey, bud, we're going to get you on our cot. Do you think you'd be helpful to that? Just a quick step over and sit down?
All right. So, again, kudos to our acting team. These guys did a phenomenal job, both our patient and psychiatric staff, as well as the EMS team that came in. Phenomenal job. So what we're trying to illustrate there is the right approach to this patient, right? They show up at the scene. It's a highly agitated scene, maybe a little bit unstable because the staff member, they seem poorly staffed, unable to fully get them under control. And the request is, hey, paramedics, step in and sedate this guy and take control. And we saw Andrew come in with his team. attempt de-escalation, and we might have all looked at it and said, oh yeah, we're going to need to sedate this guy, and still they made the effort at de-escalation, because I've encountered many situations where we didn't think it would work, but it's worth giving a shot in any event. They attempt to get de-escalation. When they conclude they can't de-escalate, we see them, there's actually a conversation. As a senior paramedic, if I look at the team and say, hey, I think we're going to sedate this guy, usually I'm going to see nodding heads, but we saw Andrew specifically ask the rest of his team, kind of like we might do in a cardiac arrest scenario as we're drawing to the end, any other thoughts, any additional thoughts? He asked, do we agree we've made the best effort we can at de-escalation, we're going to proceed with chemical sedation. The team's in assent that that's the right move at this point. They talk about what agent to use. They don't specifically talk about droperidol, but they come to an agreement that ketamine, this guy's severely agitated, it's an unstable situation, they need to gain control. Ketamine is the right agent, and clearly it is the right agent. There's then a conversation about, hey, how are we getting set up for this? And I think some of the audio was a little bit hard to hear, but Andrew was actually directing the team. He said to one of his partners, hey, I want you to be focused on monitoring this patient's airway and breathing. Let's go get the monitor and bring it over to the patient's side. We might attempt to get a set of vitals, but we saw the patient being very agitated, difficult to get more than just palpating a pulse, looking at skin signs, assessing the patient's breathing. Partner then went, we saw him getting out a bag valve mask, getting out resuscitation gear that was going to be immediately available, not back in the truck, not up in the bags, but immediately available for that potential risk that the patient becomes unstable, their breathing slows, and they become apneic. Had everything ready to go before they proceeded with the actual sedation procedure. And then we saw them do the medication cross-check. And this is another topic, kind of beyond death in custody, maybe a bigger topic, where around the country we're seeing organizations and medical directors ask, how do we ensure that when our our providers are using high-risk medications like sedatives, like ketamine, or paralytics like rocuronium for RSI, how do we ensure that those drugs are the right drug being given and the right dosage? And we all have procedures in place. The 5 rights is for helping ensure that, but we're still seeing around the country medication sentinel med errors occur, in some cases significant liability for providers and for organizations associated with it. So I think we're all rightly saying, how do we build better systems to help keep patients safe and help keep our providers safe? Because when these sentinel med errors occur, they can be catastrophic, not just for the patient, but for the provider and for the organizations involved. So you saw them have a conversation about the dose of ketamine. Hey, what do we think the guy weighs? They agree on sort of the estimate. They translate it correctly into kilograms. They look up their dose. They calculate their dose. It doesn't have to take a lot of time. It can be done quickly. And then you see Andrew reconfirm it with the other paramedic on scene. Hey, I'm going to give ketamine. This guy weighs 200 pounds. He's 90 kilos. That yields a dose of 360 milligrams. You heard him say my concentration is 500 milligrams and 5 mLs. That's going to be 3.6 mLs. I'm pulling up, reconfirms with the other paramedic. That medication cross-check beyond the 5 rights, however you do it, is a crucial aspect we're finding of how we ensure that even in these, like, there was a lot of pressure there. The guy was a little bit unstable, and I even felt my own anxiety, hey, let's get this done. And yet Andrew resisted that push that he was getting from the staff in the situation to say, yes, I'm going to do this thing I need to do to make everybody safe, but I'm going to do it in a safe manner so that we don't exacerbate and create new risks along the way. Give the medication completely on top of monitoring the patient, directs one of the providers, because you can't always get them. It'd be great to have end-tidal and pulse ox from the moment you push the ketamine. It's not going to work, right? So as a provider focused on that patient, paying attention to the airway and breathing, ready to alert the rest of the team if there's a problem. By the way, I didn't mention, and because it didn't come up in this scenario, this patient was seated with unrestricted breathing, right? We do sometimes come in these situations where the patient, maybe they're prone, maybe they're supine with somebody sitting on his chest, but they are having difficulty breathing. They're hypoxic, they're acidotic. We didn't get to see that piece of reposition before you sedate, but in his mind, as he's prepping for this, he's assessing that this patient doesn't have any limitation. There's no straps around his chest, for example, as we might see in a restraint chair in a jail, where that might be restricting his breathing. So Andrew was ticking that off in his mind as he was approaching this patient. Got the patient sedated, full focus on him, instructions to get him on the monitor as soon as they can, resuscitation equipment ready, move them over to the stretcher, and most of the time this is going to go smoothly. As long as you planned ahead for it, it's like taking the umbrella and not having it rain, right? Most of the time when we do these preparations, they're not going to be necessary, but we need to do them because every once in a while the unexpected happens, and they were completely ready to go if that occurred. Andrew, this was your scenario. You guys did an awesome job. Any thoughts on it, getting to watch yourself on tape?
Well, we sort of had the cheat sheet, right? So that helped, but it still was sort of awkward. There wasn't a whole lot of preparation time. We went in, so it did sometimes feel like a little bit tough to manage. It's 1,000 times worse when you're actually in it. You have cops, you have, a lot more stimuli for yourself, not just for the controlled sort of film. So I would just say that was tough, just trying to videotape it and then do it out in the field just makes it that takeaways from kind of your presentation, like the team approach, the communication, interdiscipline. We've got cops, we got us, we have different priorities. There is a lot of moving pieces. It can't all just be the ALS skill. Everybody needs to know it's going to take a minute. Everybody needs to be looking for these things. I think it's all pretty impactful information. So that's
but hard to slow down when you feel
hard.
The pressure.
Absolutely.
I think
even just that.
And I think a big thing to note is that cross-check or that verbal confirmation, that happens outside of just what we do, right? People that perform their jobs at the highest level, right? Whether it's in an operating room, in an airplane cockpit, right? That's something that happens very regularly when using checklists, right? They're saying these things verbally. We do it on codes a lot. Use that analogy, right? Hey, push an epi. Okay, so I know as the officer, right? I'm marking that in the hint heavy, or we're marking an event in the monitor. Whatever it is, hey, did I miss anything? We've done this, and this, right? That verbal confirmation is not just important to us, but people that perform at the highest level do it, and it's good checks and balances to help us slow down.
Right. And we see a pedigree change. I mean, we are seeing it everywhere in EMS where doing stuff out loud is becoming the norm. It is expected. And if the camera is on from the police side, then you're protected, right? People can hear that you're making that assessment. Therefore, you're covered for having made that assessment because you did it out loud. It's not just in your head. The whole, I wanted to add the whole trust but verify, which we push a lot in this office in common competency, really applies to all of us in that scenario as well, because regardless of whether you are the first arriving EMS or the second medic on the scene or an officer coming in later on, you have to make your mini assessment of the situation, just like the first provider has to make that assessment. If not, things fall through the crack and we rush things the wrong way. So yes, you can trust what people say, but do make your own assessment and bring your tools with you because you don't know what the situation is going to be.
Yeah.
I think 60 seconds at this point may be helpful to put in perspective what we were talking about when we were talking about what we saw with Mr. Britt, drenched in sweat, the way he presented, the way that these patients presented and anticipating issues. We didn't talk a lot about the potential for metabolic acidosis, but one of the reasons I mention it, the medicine and the physiology of that, is these are patients that may be trying to blow off their CO2 when they're profoundly acidotic, and the way to do that is by breathing hard. So when a patient that was previously noisy gets quiet, or there's a change in the pattern of breathing, and you are verbalizing together how someone should watch that, someone monitor their situation, even if they don't have the leads on. It doesn't take but one more minute of potential prone restraining, or it doesn't take much of a change in their breathing pattern to be the cliff that they're falling off before they go into cardiac arrest. So remembering also that patients who are profoundly metabolically acidotic are also the patients that once they do arrest tend to be harder to resuscitate successfully and get ROS. So it's worth mentioning that, because when we prevent the arrest in the first place, just like we talk about in the clinically unstable patient in general, we have a much better chance of having a better outcome in those subgroup of patients where things don't go particularly well. So acidosis is a common theme we should be aware of, especially the medics.
Yeah, and I want to pick up on what Dr. Stone just said. I do think that many of these patients, we think about hypoxia in the context of restricted breathing, but the reality is many of these patients are profoundly acidotic. In fact, it may be the principal cause of death for some of these patients. And as medics, at least when I think back to medic school, we didn't talk a lot about metabolic acidosis, at least in this context. Sure, the DKA patient, the aspirin overdose, we're thinking about metabolic acidosis, but not so much here. And I think what Dr. Stone just said, we see these patients breathing quickly and deeply. It may not be hypoxia. As a consequence, you may not be able to fix it by throwing an out-of-breather mask on. If they're profoundly acidotic, they're breathing that deeply and quickly, is what he just said, but I want to reinforce this here. They're breathing that quickly and deeply because they're attempting to compensate by blow of CO2. It does not take much restriction on their breathing, either from being held prone, from a strap around their chest, or our sedation can slow their breathing enough to push them over the edge. And once they fall off that cliff, as Dr. Stone said, they are all done. I think looking for increase in compliance, where they're starting to calm down. Is it sedation? Is it that they are becoming more compliant? Or are they beginning to become altered due to hypoxia or acidosis? And interestingly, on the police side of the work that I do, they're making that same instruction to their officers. A suspect that becomes more compliant, that isn't necessarily a good thing. You have to watch out for medical deterioration. The final thing I want to follow up on that we just cannot emphasize enough is what's sometimes called performative EMS. It's this concept that because here in the county, all of the county police officers are wearing body cameras, right? Most of us are pretty alert to that fact, but you need to have the assumption, whether it's a Ring doorbell, a cell phone, or a body camera, that you are on camera 100% of the time. And in some ways, I hate the concept of performative EMS, but with my attorney hat on, I have to tell you that the ability when you're on scene to articulate out loud what you're doing, both so you have that shared mental model with the team. Some providers routinely do this already because it's a great way to ensure that you've got, from a CRM perspective, that shared mental model. And if we're on camera, and this is the kind of call, as these often are, that can end up in court or end up in front of an investigative review panel, right, or worst case, end up in a criminal proceeding, then you want to have articulated your thought process out loud and be very clear. I'm trying to conduct assessment. I'm having some difficulty because the patient's so agitated. I'd love to get a pulse oxygen title, but I can't right here. Hey, I want you to get all the monitoring stuff so we're set and ready to go. I want you to get all. By doing that out loud, almost like, think back to when you were going to that national registry station and your instructor said to you, hey, articulate everything out loud so you get credit for everything you're doing. It's the same exact concept here, and it has the side effect that from a CRM perspective, it's an incredibly productive thing to do in terms of building that shared mental model, especially in these high-stress calls that we go on.
Yeah, no, I think that's an excellent point, and yeah, it's an excellent way to end, just to have everybody keep that in the back of their mind. So that does bring us to 90 minutes. It felt like a quick 90 minutes. Again, a lot of really good information. So I want to say thank you again to Eric for joining us. I think it's an excellent opportunity for us to learn from somebody outside the organization. So thank you very much for being here. Thank you to the rest of the panel for joining us. I also want to thank the digital media team. I think sometimes people just think this stuff happens by accident, but just so you guys know, like, that stuff was recorded this morning, like only an hour or so before we went on, and they filmed, did all the editing and everything, and they do an awesome job. So thank you to those guys. We are filming some other episodes and podcasts that we have in the works, so we'll hopefully get those to you in the next couple weeks. But until then, thank you again for joining us.